I'll go ahead and admit those who are in the waiting room now. Welcome. This is Sophia Hassan of the Reproductive Health Supplies Coalition. We'll be starting this webinar in just a couple of minutes. Welcome. We'll be starting this webinar in just a couple of minutes. Hi, this is Sophia Hassan of the Reproductive Health Supplies Coalition. Thank you all so much for joining us today for this webinar of the Safe Abortion Supplies Workstream of the NERT Caucus. Please do keep yourselves muted unless you're speaking to the whole group. And at any time, feel free to enter comments or questions into the chat box. We will have a Q&A at the end of the webinar, and your questions can be addressed at that time. This webinar will be moderated by one of our SAS Workstream co-chairs, Natalie Kapp. So I'm pleased to hand off to Natalie now.
Hello, everybody. Welcome to a webinar that we are very excited about. Today, we're hearing from colleagues at UNFPA on UNFPA's work on comprehensive abortion care. And I'm very pleased to introduce both of our speakers today. So we'll have two presenters. The first is Francelle Toedtli, who has over 14 years of global health experience in organizational strategy and policy development, program design, management, and technical support. She's worked with the Global Fund to fight AIDS, tuberculosis, and malaria. She's worked with IPAS, and she's also worked in the private sector. She's currently a technical specialist for SRHR and maternal newborn health at UNFPA headquarters, where she serves as the global focal point for comprehensive abortion care. And following her presentation, we'll hear from Stephen Mawa, who is the head of demand and supply planning at UNFPA's supply chain management unit in Copenhagen. He oversees last mile assurance and supply chain system strengthening work. And with that, I'll hand it over to Francelle. I will just reiterate for anybody who joined late that if you have questions that come up as we're hearing the presentations, please just type them in the chat. And we'll have a question and answer period after we hear from our colleagues. Okay, Francelle.
Thank you, Natalie. Hello, everyone. As Natalie mentioned, my name is Francelle Toedtli. Thank you to the RHSC for inviting me and my colleague Stephen to speak today. It's a pleasure to be here. You can advance the slide, please. So to frame our conversation today, I'm going to speak to UNFPA's work on comprehensive abortion care as grounded in the International Conference on Population and Development and our organizational strategic plan, which runs from 2022 to 2025. I'll give you some information on the comprehensive approach that we take to improving sexual and reproductive health and rights, discuss some of our programmatic work on comprehensive abortion care, or CAC, and how we plan to take it forward before handing over to my colleague Stephen for a presentation on the procurement of CAC commodities. Next slide, please. At UNFPA, our work is guided by the ICPD Program of Action developed in 1994, which frames work on abortion around preventing unintended pregnancies, preventing unsafe abortion, improving access to safe abortion care to the full extent of national laws, and post-abortion care everywhere. So when we refer to comprehensive abortion care, this is the working definition that we use. Our organizational strategic plan keeps the vision and the goals of the ICPD alive and focuses on 3 key transformative results that we aim to achieve: ending preventable maternal deaths, ending unmet need for family planning, and ending gender-based violence and harmful practices. In order to achieve these results, we must tackle unsafe abortion and access to comprehensive abortion care. 25 million abortions took place each year from 2010 to 2014. And between 5 and 13% of maternal mortality globally is attributed to unsafe abortion every year. The linkages between unsafe abortion and maternal mortality are clear. And in addition, as reported in the UNFPA State of the World Population Report in 2022, 61% of unintended pregnancies end in abortion. And we know from WHO that 45% of abortions are unsafe. So the transformative result related to ending unmet need for family planning is also linked to the incidence of abortion. The contribution of unsafe abortion to maternal mortality and the need to tackle it, as well as expand access to abortion care, are part of an integrated SRHR package of interventions indicated in our strategic plan and its associated documents. In the global program, UNFPA pledges to support country and regional offices in their support to governments to prevent unsafe abortion and improve access to care. Regional plans discuss capacity building around improved quality of care and health services, including through the training of midwives, as well as the strengthening of EMOC, emergency obstetric and newborn care networks, which provide post-abortion care and in some cases, comprehensive abortion care as well. Next slide, please. UNFPA advances the Guttmacher-Lancet definition of comprehensive SRHR. A comprehensive definition of SRHR and an essential package of services and information is the foundation of our work. And this package includes comprehensive abortion care, counseling, and services for modern contraceptives, and a range of other services that you can see here. Recognizing the evolving nature of health-related needs and preferences, UNFPA takes a life course approach, meeting individuals with tailored care when they need it. And underpinning this approach are 3 central tenets: equity and access, ensuring that everyone, no matter what their circumstances, has access to care; ensuring high quality care, as we know that even where there is access to services, quality can be lacking; and accountability, to hold healthcare providers and policymakers accountable for delivering quality care to citizens. Next slide, please. We see midwives as the center of this approach. Empowering midwives promotes the health and well-being of women, girls, and their communities, saves millions of lives each year, contributes to national and local economies, fosters women's empowerment and gender equity, as the vast majority of midwives globally are women. Globally, there's a shortage of midwives, and more needs to be done to invest in them as a critically important cadre, providing SRHR services across the life course, empowering women and girls to choose if, when, and how many children to have. Midwives contribute to antenatal, childbirth, and postnatal care, but also a breadth of SRHR services, including contraceptive counseling, comprehensive abortion care, where permissible, and support for self-care interventions and approaches. The fact that midwives work in and are part of their communities means that they're also well suited to support sensitization and awareness raising on SRHR, shifting social norms that limit women's ability to exercise their SRHR, gender transformative approaches, the provision of social support, and promoting empowered choices by women and girls related to abortion. Next slide, please. There are a number of ways in which abortion is integrated across UNFPA's work and practice. As part of the Maternal and Newborn Health Thematic Fund, the MHTF, abortion is part of a package of comprehensive and integrated interventions that I spoke to previously. Our work to strengthen health systems across building blocks is delivered through the MHTF, which works across 32 of the countries with the highest burden of maternal mortality and morbidity globally. And our midwifery and EMOC work is delivered through the MHTF. UNFPA integrates comprehensive abortion care elements into EMOC needs assessment tools and monitoring frameworks. The EMOC needs assessment process evaluates the ability of the healthcare system to deliver EMOC services, which in our framing includes CAC, comprehensive abortion care. Needs assessments also include a prospective analysis of how to improve service delivery and address gaps and issues related to EMOC. These assessments cover services across a country and thereby play critical roles in assessing the health system's preparedness to deliver services and informing UNFPA and partners on how to support governments in their efforts to improve quality of care and equity and access. The assessment includes 12 modules that cover different elements required of a functioning EMOC facility, including human resources, essential drugs, equipment and supplies, EMOC signal functions, and other essential services, as well as provider knowledge and competency. In 2020, UNFPA developed content on CAC that was then integrated across each of the relevant modules to ensure that information on CAC as an essential service is captured through these assessments. The updated assessment tools were piloted in Rwanda in 2021, and the results are under final validation by the Ministry of Health. In terms of midwifery, UNFPA has worked with the Maternity Foundation to develop a CAC module as part of the Safe Delivery mobile application and job aid for healthcare providers. We're also working with the International Confederation of Midwives and the Liverpool School of Medicine to develop a sample CAC module for a midwifery curriculum that will be part of the new UNFPA and ICM direct entry and post-nursing midwifery curriculum. And that's aligned to the latest ICM competencies. Next slide, please. Another UNFPA initiative that includes a strong focus on CAC is through the CETA-funded Together for SRHR program. This is a joint effort. The program includes UNFPA and WHO. It applies a regional approach, country-to-country sharing as a key component, and it covers a range of SRH areas, including abortion, and looks really towards the integration of SRH services. Activities include providing support to regional processes of the Southern African Development Community, SADC, and the East African Community, the EAC, including advocating for the EAC SRH bill that would hold governments accountable for improving access to SRH, and the SADC SRHR scorecard, which was passed in 2021 and consists of 20 key indicators to track progress in meeting the 10 outcomes of the SADC SRHR strategy, including related to abortion and the integration of services. In terms of capacity strengthening, they work on healthcare provider training, as well as values clarification and attitude transformation. The ESA Regional Office conducted an in-service CAC assessment to assess the level of preparedness to deliver CAC services across 4 countries in the region, Ethiopia, Kenya, Malawi, and Mozambique. They also do work to address social and gender norms, including engagement with communities around SRHR topics like HIV, STIs, cervical cancer, GBV, and CAC through dialogues and promotion and distribution of information, education, communication materials, as well as working with community health workers. They focus also on evidence generation, including the development of WHO strategic assessments on unintended pregnancies, contraceptives, and unsafe abortion in Botswana, Eswatini, and Namibia. They also work on resource and material development, so developing policy briefs for Botswana to interpret the data from the strategic assessments, evidence briefs, for example, on the impact of the legal context on the maternal mortality ratios in the region, as well as how to build champions for SRHR. A regional advocacy and research working group was established with WHO, Guttmacher, IPPF, APHRC, and others, and the group has supported the review and development of some of the resources I just mentioned. This program also supports the development of, or the framework through which this program works is really by developing country roadmaps on unintended pregnancies and comprehensive abortion care, whereby country teams, including civil society organizations, ministries of health, UN agencies, and other partners jointly determine plans to be supported through the program for the upcoming years. Next slide, please. The Access Project was a 3-year project from 2020 to 2022, and it was the first dedicated global abortion-focused project at UNFPA. The focus was on reducing maternal mortality by improving access to comprehensive abortion care, with a strong highlight on expanding the range of reproductive health commodities available in countries, especially medical abortion and the combination regimen, conducting global and national advocacy to raise awareness of CAC as part of an integrated package of services, engagement with communities around information sharing and sensitization on local legal contexts, and strengthening health systems, focusing on training of healthcare providers and service delivery to improve access to care. Work was implemented across 6 countries: Benin, Ethiopia, Kenya, Mozambique, Rwanda, and Zambia. Next slide, please. In Benin, they conducted CAC trainings that focused on medical abortion with midwives as well as with midwifery training instructors across training institutions and within EMOC facilities. They also conducted a number of trainings with pharmacists on medical abortion to ensure that they are aware of regimens and can provide accurate information to clients. They are conducting values clarification and attitude transformation with healthcare providers. They are conducting a number of monitoring and coordination meetings across regions and facilities with the Ministry of Health. And they're working to integrate the combination regimen into national logistics management systems in country, as well as strengthening the supply chain. And we'll hear a lot more about that from my colleague, Stephen. So in Benin, we're working with the Ministry of Health, with local IPPF partners, as well as WHO. Next slide, please. In Ethiopia, UNFPA conducted a CAC training of trainers for healthcare providers across Cadre. Through the project and with the Ministry of Health, UNFPA is providing supportive supervision across sites, conducting VCAT trainings with healthcare providers, values clarification and attitude transformation, conducting integrated life skills training, as well as values clarification for adolescent community members, updating national clinical standards and guidelines on CAC to align, further align with the WHO abortion care guideline, and those are still being reviewed and approved. Sensitizing civil society organizations and professional associations on their roles in preventing unintended pregnancy. Engagement and sensitization of local opinion leaders on SRHR issues, so comprehensive abortion care, as well as gender-based violence, to support women's access to care. And they're also holding community dialogues and sensitization in public areas, as well as using information education communication campaigns. And in Ethiopia, our partners include the Ministry of Health, MSI Reproductive Choices, and IPAS. Next slide, please. In Kenya, our work includes supporting post-abortion care trainings with various cadre providers. On the prevention of unintended pregnancy side, we've conducted trainings on family planning methods for healthcare providers, as well as procured pelvic models to support quality trainings on post-abortion care. Next slide, please. In Mozambique, we are conducting CAC trainings that also include values clarification. Supportive supervision visits were conducted in partnership with IPAS and the Ministry of Health. UNFPA is also supporting the mentorship of healthcare providers and the training of mentors. Community engagement is a big focus through community debates, radio programs, and local magazines with content on SRHR. We have supported dissemination meetings on the WHO abortion care guideline, and the guideline is still to be updated. We are also strengthening logistics chains and capacity building around that whole process. And we've also conducted bias clarification trainings with local government members and community members, healthcare providers, traditional birth attendants, and others. And we're working with Ministry of Health, IPAS, WHO, and others in country. Next slide. In Rwanda, we're also conducting CAC trainings, including on the use of ultrasound, which is still a prerequisite for access to comprehensive abortion care in country. And it was identified as an area on which providers needed additional training and support. We also piloted a mobile mentorship approach called the Mobimenta program, where mentors travel with simulation equipment to health facilities in order to train healthcare providers on important competencies and update them on national guidelines related to CAC and family planning. We supported the updating of national clinical standards and guidelines to better align with WHO and are now supporting the dissemination of those guidelines. We've conducted values clarification trainings with various stakeholders, including healthcare providers and support staff at facilities. And we're conducting community sensitization on CAC, including awareness meetings with adolescents and adolescent mothers, facilitating support to an SRHR hotline for adolescents, developing peer education approaches, conducting dialogue with schools, parents, and youth on the legal context for abortion, family planning methods, and social reintegration of adolescent mothers. And in Rwanda, we are working with the Ministry of Health, WHO, and others as well. Next slide, please. In Zambia, we supported a national values clarification and CAC training of trainers, which included a focus on youth responsive services. We supported the Ministry of Health to develop a CAC training package. We are strengthening supply chains, focusing on the quantification of needs, accountability mechanisms, and distribution and management of CAC commodities, and monitoring of commodity supply. We supported the Midwifery Association of Zambia in training nursing and midwifery instructors on CAC mentorship and capacity building. We're supporting the scale-up of the e-signature platform for terminations of pregnancy. In Zambia, 3 provider signatures are needed to deliver a termination of pregnancy. So an e-platform facilitates the receipt of those signatures, especially in areas where there aren't many healthcare providers. And we've advocated with the Ministry of Health to include medical abortion medicines on the EML in the clinical guidelines and the National Drug Formulary. We've conducted values clarification trainings with various stakeholders, including the Ministry of Health. And a national advocacy team was formed and named the Safe Abortion Action Group, technical working group rather. Members include professional associations of midwifery, gynecology, NGOs, UN agencies, and others. And UNFPA is involved in that working group. We also supported the integration of CAC into the National Reproductive Health Policy, which is the first revision of the policy since 2008. And that was through that technical working group. And UNFPA has supported updating the national clinical standards and guidelines to align with WHO as well. And we're working with a range of partners, again, Ministry of Health, local MSI chapters, and then professional associations and others. Next slide. So I hope that gives you kind of a flavor of all the work that we're doing. There's quite a lot. So this is my last slide. As we look forward as an organization, there are a couple areas that we plan to focus on. So systematizing lessons learned and best practices, focusing on documentation of the work that we've been doing, including highlighting successes, but also areas of challenge, spotlighting interesting approaches in countries like the e-signature approach in Zambia, Mozambique's journey to expand access to care, but also looking at mentorship approaches across contexts. Organizationally as well. So for example, looking at the regional approach that's used in ESA and how that might be replicated in other contexts. And this work really aims to break down silos and encourage cross-learning, demonstrating the type of work that we as an agency can support across contexts, including legal contexts, and developing tools and guidance to that effect. In order to support the integration of CAC within and across UNFPA programmatic efforts, there's a focus on making connections between various internal units in terms of thinking, strategies, and approaches. For example, at the global level, we'll be working across SRH and gender and human rights areas to ensure elements of gender equality and stigma are integrated into our approaches and aligned with our strategic plan. Also focusing on ensuring that as an agency, we are well positioned to work on CAC, including strengthening values clarification, approaches both internally and externally in our programming with partners. We will also focus on continued and strengthening existing programmatic efforts on CAC across the globe. We're actively fundraising to be able to expand on the work we're already doing within and across countries, focusing on strengthening national data on CAC, healthcare provider trainings, on-site mentorship and supportive supervision for providers, supporting the finalization and dissemination of updated clinical guidelines on CAC, values clarification, equipping healthcare providers, healthcare facilities rather, with supplies to deliver CAC, and strengthening commodity quantification and tracking. We will leverage the UNFPA strategic plan. So using the inclusion of a focus on preventing unsafe abortion and post-abortion care as well as an opportunity to spark internal conversations on these topics and to grow our community of practice internally and our programming externally. Also strengthening our understanding of gender-based and human rights, rights-based approaches as regards CAC, as I mentioned before. And then growing and maximizing our partnerships, again, aligned with the strategic plan, looking for non-traditional partners as we cement our work in this area, looking to engage more with feminist and women's movements, community-based organizations, and others to advance this work. Thank you all for listening. That was a lot of information. I will hand back to Natalie. Thank you.
That was terrific. Thank you so much, Francelle. Why don't we move ahead to hear from Stephen, and we'll just take questions at the end. So for anybody who has questions for Francelle, write them in the chat and we'll get to them at our question and answer time. Stephen?
Thank you, Natalie, and thank you, Francelle, for that wonderful presentation. It sets the stage for, I think, what I'm going to talk about, and I'll focus more on our work in terms of supporting procurement of safe abortion supplies. Next. 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 Okay, so I love this piece because I picked it from the WHO conceptual framework for abortion care. I love it because I have two daughters who are budding artists, and they always come home with lovely drawings. I was kind of impressed when I saw this framework because in this one piece, all the work that we need to do to advance access to safe abortion supplies is captured. But of all these pieces, it's the commodities that is the missing link that can make or break us. And I say that because reflecting back on my experience before I joined UNFPA, I was working in a locum pharmacy, and this young girl walks in asking for aspirin, but what she wanted was not actually aspirin. So judging by the timid look and the way she wanted privacy, I decided to probe a bit more, only to realize that she was sent to the pharmacy by a nurse who knew she was pregnant, but was not willing to give her any medicine that could help her terminate her pregnancy. So she came to the pharmacy with a prescription for aspirin from that nurse. Of course, aspirin can't terminate the pregnancy, but the pharmacy was not also stocking any abortion supplies because of the legal restrictions in the country where I was working. and I kind of felt helpless. The girl walked away, but when she walked away, I let her down. But working with UNFPA now and having this global movement that is trying to support girls like her, it makes me think it wasn't only me who failed her. We failed her as a community. We failed her as a health system. And for that matter, the work that we do will make a big difference if we make commodities available when and where they're needed. And that's what I'm going to talk about. Next. So to me, it's really like walking a tightrope because we're operating in an environment where in many countries, there are a lot of legal restrictions on what products can be available for girls like this patient who came to me. We are also aware of nurses like the lady who referred her to the pharmacy who have their own views, and that the views they hold and the attitudes they have actually prevent young girls like her from accessing the products that they need. We're also operating in an environment where the market factors are dynamic. We have limited suppliers who can provide quality assured, safe abortion supplies. We also have to deal with prices that may limit access to those who cannot afford. And of course, even some of the suppliers who are available have restrictions on the minimum order quantities that you can place. So if you don't have significant volumes that you're procuring, you may not be able to buy these products from those manufacturers. And on the demand side, I think Francelle talked very well about this. So unless we address some of those factors, also having the commodities alone may not make a big difference. In terms of supply chain management, we are quite aware in many countries because of the issues around safe abortion supplies. The products are managed as a vertical supply chain. And this in a way limits access to some facilities. And lastly, WHO sends out alerts on counterfeits, substandard products all the time. Unfortunately, one of the products that are commonly counterfeited are actually products that are used for providing abortion services. So with all this, there are a lot of issues that we need to take into consideration when we are talking about supply chain management, and that goes beyond just procurement. Next. So reflecting a bit on the work UNFPA does on procurement of safe abortion supplies, there are many factors that we look at. On the product, of course, for us, it has to be quality assured. And that means the product has to be either WHO pre-qualified or registered in a country with stringent regulatory authority. The product also has to be one that is in the WHO model list. And of course, in the WHO abortion care guidelines. At the country level, if we are to provide the product in a country, we also look at the registration status and if this product is actually on their national essential medicines list. And that's why Francelle talked about the importance of the work we do in ensuring that the local protocols reflect the type of supplies that are required to provide safe abortion services. Then in terms of sourcing, I talked about manufacturers and pricing, but also the production capacity is an issue because we are thinking long-term in terms of the future where maybe the demand for these products will go up, and would want to work with manufacturers who will have that capacity to step up in case the demand also goes up. And then before we also do procurement for countries, we do some kind of readiness assessment. If, of course, the legal environment allows procurement and distribution of the product, if the introduction plans in place, and if these introduction plans are actually resourced, there is plan for capacity building. It's not just about dumping the products in the country, but there's a plan to have it distributed up to the last mile, monitored and reported on to inform our planning and of course forecasting for future procurements. Then there's the element of financing. We don't expect to be donating products to cover all the needs in a given country. So it's important to see if there are synergies, if the government is also able or planning to step in and do the procurement beyond the support we provide for introduction. If maybe there are other partners who can bring resources to bear to support work on demand creation, on distribution, as well as the capacity building that is required to strengthen the supply chain. Next. So briefly, this is how we go through our product selection, the importance of having it in the global guidelines, the WHO model list, and of course, taking into consideration the UNFPA quality assurance framework. And based on that, we go through our procurement processes to identify the suppliers and then have their products placed on the UNFPA catalog. So broadly, we have pharmaceuticals, we have safe abortion supplies also in the interagency reproductive health kits, and we also have the standalone MVA kits that are in our catalog. Next. This slide is just a summary of the different products that we have in our catalog. You can see we have a limited number of suppliers for these products. We also have arrangements where we have suppliers who are not necessarily manufacturers, but who source from the manufacturers. And this is important for us because it gives us some leverage in case we have a country that's requesting for quantities that may not be supplied by a manufacturer because of their limitation on the minimum order quantities. The suppliers may be able to buy in bulk from these manufacturers and then aggregate demands from a number of countries and meet the needs of those countries where the volumes are low. So that's why you see we have different categories. We have the manufacturers with whom we contract directly, but also the suppliers that may help us to mitigate some of those challenges. Next. So in this slide, I just wanted to show some of the volumes that we have been able to procure in the last 3 years. For Combipack, in the last 3 years, we have been able to supply to 11 different countries. It started very well. You can see in 2020, that was the year when we launched the Access project. And of course, a number of countries came forward with ambitious forecasts. So relatively, the procurement was high. And some of that supply, of course, lasted up to the following year. And you can see it's kind of stabilizing around there. Next. The MVA kits also, for the last 3 years, we have been able to procure for a total of 22 countries. And I won't say the demand is going up, but you can see from the graph that last year has been quite busy. We are yet to see if we can maintain that or even surpass that by end of this year. The next. For misoprostol, we have been able to procure for 54 countries. And this is partly because misoprostol is not only used as a safe abortion supply, but it's also used for other indications like PPH. So probably there is an overlap here. We cannot say how much of this was used for medical abortion. And therefore, we just wanted to show this and underscore the fact that not all these 54 countries might have done this procurement for safe abortion care. And then also, you can see maybe in 2022, the quantity has gone down a bit. This is also partly because, remember, during COVID, some countries diverted resources for procurement of medical supplies to buy maybe PPEs and so on. And because of that, misoprostol is one product where countries invest. They buy for PPH and not only for, of course, abortion care, by diverting resources, we think maybe it contributed to the drop in the procurements that was done in 2022. Next. Then for other supplies from the interagency reproductive health kits, these are mainly what we procure for our humanitarian programs. And as I highlighted earlier, these are kits that also contain misoprostol. And we have been able to provide this in countries. We now have a kit that is basically having misoprostol only. There's also a kit that is having mifepristone only. And so far, we have only one country that has ordered for misoprostol kit, the standalone, and that's Ukraine. We have seen also some countries expressing interest in buying more of that this year for their humanitarian program. Next. So overall, just to summarize, our approach in terms of managing safe abortion supplies is really around partnerships and coordination. We don't work in isolation. We try to liaise with other stakeholders who are involved in this work in the countries that we work in. And this includes facilitating technical working groups where the quantification, distribution planning, and so on for safe abortion supplies are discussed. We also try to ensure that when procurements are being done, this is aligned with the plans for capacity building so that products don't get to the country and they sit in the central warehouses for some time, especially Combipack that has a short shelf life. So to maximize that, we make sure that the procurements are aligned with the trainings. Then we also emphasize, like Francelle said, systems strengthening approach. As much as possible, our procurement and supply chain work is government-led, of course, with the technical working groups spearheading the coordination. We also promote integrated programming, especially with the work we do in family planning. The post-abortion family planning especially is also key in trying to make sure that we just don't only focus on one piece, but integrate the procurement, distribution, and availability of this product in the broader SRH program. Then we have also we place a lot of emphasis on quality assurance by sticking to WHO pre-qualification and registration in SRA countries. We are trying to also encourage other partners to follow the same pathway so that we can safeguard the quality of products that are made available. Through our other programs like UNFPA Supplies Partnership, we are also providing funding for supply chain systems strengthening. We also have other resources like for technical assistance for enabling environment, where we do support governments to update their EMLs, and also the seed fund for some of the trainings that are required before products are introduced. Finally, we have the last mile assurance work, which helps us to monitor the distribution of products to the last mile and also give us reports. So in our quarterly reporting system, we have integrated these safe abortion supplies now. So moving forward, we will be able to get some kind of visibility on where the products go and how they are used. Next. This is just a picture from a workshop we conducted in Rwanda for our country focal points. We realized that our country focal points are gatekeepers when it comes to inclusion of products in national supply plans. And as Francelle said, the value clarification and so on is not only for our partners. Also internally, we need to have this conversation and create awareness among our staff. So this workshop was partly aimed at doing that, but also to share experience across countries on how different countries are approaching their work on integrating safe abortion supplies into their national supply plans, and how they can do their forecasting and ensure that safe abortion supplies are part and parcel of that. to the full extent of the law. Next. So in conclusion, I would like to say products hold the key. Without the right products, regardless of what we do, that young girl will not be able to get the product she needs to go back to school. Secondly, we tend to focus more on numbers, procurement numbers. What are you buying? Where are you buying? And so on. But procurement, as far as I'm concerned, should be coming at the tail end after we have done the donkey work with the regulatory framework, the trainings, and of course, strengthening the supply chain to be able to absorb and distribute these products up to the last mile. And then thirdly, integration is something that we cannot overemphasize. You can't do this alone. It's important that availability of safe abortion supplies is seen as part of the broader SRH programming, but not as an isolated product. And we have examples in countries where this has worked well, like in Benin, where they have the informed push for essential medicines. And when we introduced the Combi Pack, they were able to also include the Combi Pack in that essential medicines distribution program. Then finally, nature doesn't like vacuum. Where we are not able to do something, trust me, there's somebody who is willing to step in. And unfortunately, those who step in may not be the professionals and good intentioned people. And that will have consequences to that young girl who does need quality service. Thank you.
Fantastic, and thank you for sticking to time. We do have a number of questions, and going to start with maybe the easiest one to answer. Stephen, what are the different types of misoprostol, P3 or P4, with no description in the UNFPA catalog?
We do have both categories, and I think I indicated that in the slide on products in catalog, where we have P3 and P4. Currently, the catalog is down because of some technical issues, which we are trying to fix. But I think when you go to the catalog, you'll be able to see the different pack sizes. The P3s and the P2s are, the P4s are there.
Okay, great. Another question to Stephen from Natalie Williams. Stephen, there's been internal discussion on the potential impact of tranexamic acid and HSC introduction on misoprostol availability. Could it have contributed to the reduction that was seen in misoprostol orders in 2022?
Well, I think we have not got to that point where we expect TXA and HSC to impact greatly on availability of misoprostol. For UNFPA, we haven't procured actually the two products to a significant extent. What I would rather say is probably governments have picked up. In 2022, they have picked up procurement of misoprostol because this is something they used to procure before COVID. And 2021, that volume went up because they were dependent on UNFPA to fill that gap. I think that is the most likely explanation for now. Maybe with time, when we have more countries introducing TXA and heat stable carbetoxin, we may start to see that trend maybe not only for UNFPA procurement volumes, but also procurement done by other partners, including governments.
And related to the COVID pandemic, there's a question about, because the pandemic had its peak in 2020 and 2021, not in 2022, that it doesn't make sense that to justify that it was COVID that resulted in a dip in spending in 2022. Are there other ideas for root causes, or will you be looking at that more in depth in the future?
Well, I think that's what maybe earlier I made a mistake, maybe in my explanation. That's why it hasn't come out clearly. But
Okay.
in what I just said, I think the dip is in 2022, right? And that's why I said that was the point where we think government started picking up the procurement for misoprostol. In 2021, they were dependent on UNFPA. And also before that, okay? And before that, governments were doing their procurement, including misoprostol for PPH, for example. But 2022, you can see from the peak in 2021, it went down in 2022. So that's why I said probably governments have started picking up. And if governments are doing the procurement, for us, we fill gaps. We don't have to procure high volumes when the governments are already doing the procurement.
Great. Okay. So question from Petra. She says, I know UNFPA has previously launched an ERP, expression of interest, for CombiPack, but there were no submissions to the last one. Are there plans to launch another one in the future? And if so, when? And is UNFPA engaged with any of the current CombiPack manufacturers?
Sure. I had a slide with manufacturers on, I think. There are 3 manufacturers that we are working with directly. So that answers the last question. On the ERP expression of interest, yes, we had poor response last year. We are currently running our mega bid for almost all the products in our catalog. We haven't opened the bids to know if there is a significant response for this product category. But we do have plans to, of course, engage with some of the manufacturers. We are discussing with some of the manufacturers who have expressed interest in getting their products WHO pre-qualified. So we hope we'll be able to add to the current number that we have.
Thanks, Stephen.
And then I can also see another question from Safia on
Yes.
the geographic regions.
Yes.
Yes, I had planned to actually include a map with where these procurements are. Unfortunately, I'm not an artist. The person who is putting that together could not beat the deadline. But if you can allow, maybe I can have it inserted and it can be shared with the slides that go out.
Yeah, that would be terrific. And so I guess that also answers the question of whether we can share the slides. Terrific. Any other questions, or does anyone want to take the mic and ask a question?
Natalie, if I could just add to Marcel's question and Stephen's response, just to say that there could be other factors at play as well in terms of the enabling environment. So, you know, trends in access, political context, changes, things like that, that we could also investigate to paint a fuller picture of why that dip happened as well. Thanks.
And just a general question for those of us in civil society, how can we work better with UNFPA and your programming?
Great question, and thank you. Don't be a stranger, approach us, you know, integrate us into the work that you're doing, invite us to the table. Of course, you know, UNFPA is a UN agency. There are, you know, limits to the remit of work that we can do on this topic, but I think through my presentation, through Stephen's presentation, we've seen that there is actually a lot that we can be doing and that we are doing. So yeah, I would say, you know, approach us if you need introductions. Stephen and I are welcome to facilitate those as well. Yeah, include us, integrate us, and yeah, we'd love to be more involved and more engaged.
Yes, I think you will be. I think This was a great learning opportunity for me, and I think for many of us on the call who haven't had a lot of opportunities to work with UNFPA in the space of safe abortion care. So I'm going to just call one last call for questions. And if we don't have any other ones, I would like to put out a plea for people who are coming to the GMM in Ghana, who are part of the work stream. We'd love to hear from you, Petra and I and Sophia, about some ideas about how to spend our time together, both in content and if you have any structural comments about or suggestions about the way that we can make the most of our time in person. It's been, I don't know, 3 years since we've all seen each other. So please just drop us a line. We're in the middle of thinking about what we're going to do during that time together. Terrific. I think we can end. And do you have any last comments, Francelle and Stephen?
I think just to say thank you. This was a great opportunity for us. And we really want to, get the word out and make sure that UNFPA, as you said, is really involved in these processes, involved in these working groups and conversations. So yeah, thank you.
Stephen?
Well, just to say thank you for the audience, and we look forward to continuing the discussion.
Wonderful. Great. Thank you, everybody. Wishing you all a nice Tuesday morning, afternoon, evening.